Hi, my name is Lauren Marshall. I am a practice facilitator for the ROMPO project, Reframing Optimal Management of Pain and Opioids in Older Adults. And we are going to talk about shared decision making today in this podcast.
And I'm Dan Berlin. I am the PI on this project and going to turn it over to Lauren at this time.
All right. So one of the first questions that we want to ask ourselves, is what is shared decision making? Because it sounds really simple, but it's a little bit more complicated. It's actively engaging and empowering your patients to be participants in their own healthcare. And so it's moving the conversation a little bit more beyond just a dialogue and coming up with actionable steps and clear goals. So the meaning is very simple, but different. So I don't know, Dr. Berlin, do you want to talk a little bit about how is shared decision making, you're really leading the patient along the process rather than telling them?
Yeah, in this day and age, patient autonomy is emphasized and essential. On the other hand, if clinicians abdicate all of their ability to guide the patient to reach the correct decision, then we're not doing our job right. And so this is a way of educating the patient and then giving them the tools to make the right decision among limited choices.
Yeah, it seems like that's a really great opportunity to demonstrate you really care about your patient and that you're interested in their opinions and their values. And especially when we're talking about things where we're really wanting behavior change, it's necessary to have the patient buy-in. And so having those conversations, talking about those options is going to be your best way for the patient to really adhere to their care plan. And that includes medications and treatments. Dr. Berlin mentioned you don't always have that many options to choose from. And so it's about trying to vet your patient's preferences. So if we're talking about clinical options for medication, we might want to really consider the frequency, duration. Where does the medication need to be stored? Making sure that the patient sort of has those facilities at home if they need a refrigerator, if they don't have access to care, if they can't get to their appointments to take their labs, maybe there's a different med that they could be on.
And an essential thing to consider that is often forgotten is, will their insurance cover what you're intending to prescribe?
Yeah, how do you manage that when it's unreasonable for a provider to know what all of the insurance, coverage costs? Is there a way that you help your patients determine that, or somebody that you can refer them to help?
With practice experience, you learn very quickly, particularly with very limited coverages such as the Medicaid HMOs.
Right. And then with Medicare too, right? There's a bunch of different types of prescription coverage, and some patients might have supplemental plans, whereas others might just be straight Medicare, and that might impact what options they have. It's also a little bit interesting too when we're thinking about working with an older generation who may not have been included as much in the medical care decisions for the majority of their life. So this might be something that's new to them, and they might really value that. Building on that a little bit further, with an older adult population, there's going to be more significant co-occurring disorders and complicated medication management and treatment plans. So having a family member there as a patient representative can help with that. Do you have experience working with family representatives or patient advocates with your patients?
Yes, and sometimes you have to sort out the bias of the family member and the influence it has on the ultimate decisions that's made by their parent or whoever it is.
Yeah. If you're talking with the patient, you're getting to know their values and trying to understand where they're at in their own understanding of their disease. You might discover that there are some social determinants of health, like housing or rides to appointments that they don't have access to. And so having these conversations, asking them these questions might uncover that. And then you can refer them to some of the community resources. There's local agency areas on aging across the country that is going to be probably the best, most comprehensive place to look for those extra services and a way that you can sort of point them in the right direction. Let's talk a little bit about how do you actually implement this shared decision-making strategies within your current clinic workflows. So we don't want to reinvent the wheel. We don't want to give any more work to anybody really on the care team, whether that's at check-in, the MAs that are the nursing staff. So coming up with ways and processes that already build off the current workflows, like maybe it's an appointment scheduling thing where you have to call the patient to get their confirmation. Maybe you use that as another opportunity to have some deeper discussions about their treatment options. How do you really incorporate that into your own clinic?
Well, you do the best you can given the limited amount of time. And so if the family member isn't there, then a phone call probably after the appointment is the best thing. You can't possibly do it during their limited time slot.
Yeah, you're definitely working within a short amount of time. So I think this is a good segue into maybe discussing a couple of your patients that you've had in your practice that show our listeners some of the ways that shared decision making has worked and give them a couple of case studies to understand this a little bit better.
So one of the cases is about giving bad news and leading a patient to the right decision about treatment. And the other one is about changing a patient's mind on what the right treatment would be after a long period of incorrect treatment. So the first case was a 63-year-old woman who actually presented to my service in the hospital with terrible epigastric pain that proved to be caused by pancreatic cancer metastatic to the liver with a huge mass diagnosed 3 months before elsewhere. And she was undergoing chemotherapy and had already had a follow-up CT scan that showed progression of her disease. So she now presented with a few days of severe pain. She had been taking Tylenol number 4, which would be approximately equivalent to Norco 10/325 tablets, and she was taking 8 a day for perhaps an 80 morphine equivalent dose per day. Socially, she was living alone in her newly acquired house, and she had excellent family social supports. On presentation, she was crying. She had a large liver mass. X-rays showed no clear evidence of obstruction, and the recent CT, as I said before, showed evidence that her masses were increasing despite her treatment. Her laboratories did not show signs of dehydration or electrolyte abnormalities. So the discussion that followed after stabilizing her pain situation by using IV PCA morphine, when she was far more comfortable, was then to proceed with a discussion about her understanding, or I should say lack of understanding, that she had been given about her disease by the treating doctors, its current status, its true prognosis, because this was really at a time where there was no chemotherapy. Now we have chemotherapies that can delay death for perhaps 6 months or so, and what options she reasonably had. So that was the information part for her. Obviously difficult for her to take, but I moved on pretty quickly to what her goals were, particularly for right now, which was obviously pain control, but returning to her home and how she would spend the end of her life. And so her goals were that she had just purchased this house and moved into it, and she loved it, and that was where she wanted to be. And if her treatment was futile and was not going to extend her quality of life and perhaps could shorten her life, she did not want to have any more chemotherapy. She was quickly converted to oral therapy and discharged to home hospice with the expectation that she would live perhaps 8 weeks, told to her. I managed her over the phone from that point on, and except for one dose adjustment that would be expected with the tolerance that people acquire to opioids, she was comfortable and actually died within 6 weeks. She, of course, expressed her gratefulness that she was able to make it home. So that was one case. The other case was a man who came to me as a new primary patient. He was 72, suffering from post-polio syndrome, which meant weakness and wheelchair use, who had a history of multi-level spinal fusion several decades before and had been on a home ventilator because of the post-polio syndrome, but mostly because of his high-dose opioid treatment that he had been treated with for a total of 30 to 40 years. So he had moved down from the Upper Peninsula to down here in Southeast Michigan because he could no longer live alone, and he had the opportunity to invest in a larger house for his daughter, who it turned out was now getting divorced. So he moved in with her into a situation of the daughter freaking out and terrible home stress, and the work necessary to get done to make him live there comfortably put on hold, which was a huge mess because of his disability and the need for a ramp and wheelchair use. So over the preceding 30 years, he had been started on Darvocet, a common low-level treatment that, when it was removed from the market, was converted to Norco, a much more aggressive treatment, and gradually increased to not the largest dose that I'd ever seen anyway, at a total of 6 tablets a day or 60 morphine equivalents. He was also chronically treated with 2.5 milligrams of Valium for sleep, not a correct use of benzodiazepine, and certainly I think all doctors have known since 2016, the highly publicized CDC guideline, that opioids and benzos are not a great pair of drugs to give together, especially when you have respiratory insufficiency and use a home ventilator. So after some conversation with the patient, he said that he was doing reasonably well on his regimen, but not great, and he was afraid to change it and did not want to change it because this is the way he had been treated for all those decades. But my goal was to convert him to buprenorphine, knowing its safety profile, not necessarily less respiratory effect, but that he wouldn't suffer from further escalation of dosing and would actually probably be better off because I could push him to higher levels. And we also talked about removal from benzo, which he agreed to. So he was eventually switched to Belbuca and arrived at a dose of 300 micrograms twice a day, which worked great. But then his insurance coverage was cut off and he had to be switched to sublingual. And after some dose titration, he arrived at a dose of 2 milligrams 3 times a day of sublingual plain buprenorphine, doing very well, saying this was the best he had felt in more than a decade, and was thinking of volunteering for a political organization. So with him, it was a matter of working on his beliefs and convincing him that change could actually improve him. And he had the courage to go for it. Incidentally, he was easily removed from benzodiazepine, never missed it, and slept fine.
Wow, those are both really great examples of shared decision making in practice. One of the things that strikes me, especially about the first case that you shared, is how, as a primary care provider, you were able to sort of look at her situation from a higher point of view and take into account some factors where, a specialist might not be thinking about the whole picture, maybe thinking about their part of it. But that's a really important way that primary care providers can really move the patient along on a treatment plan that works. And with the second case that you shared, the man expressing fear over changing his medications, I can definitely empathize with that, and change is scary. And so coming up with a way where you can have those conversations to get him to the point where he's ready to change seemed to be pretty impactful.
So with the first one, I kind of had a dual role because by then I was already working pretty much as a pain doc as well. So that's why I was able to get her pain under control so quickly. Then that permitted an easy transition to a homegoing regimen. And of course, our discussion, it facilitated our discussion during what would be an acute phase. And I was a new person to her. So she didn't really have to believe anything that I said. In the case of the second one, he could have been a good example of a patient who would say, and I'm sure everybody's heard this, I know my body and I know what I need. And unfortunately, they may know their body, but they don't know where their decisions come from. And so they have to be exposed to additional possibilities after you've convinced them that you've heard them out.
Yeah, which seems like it's probably not always that easy. You probably face quite a bit of resistance when you first start out on those conversations.
That is true.
Well, great. Thank you so much, Dr. Berland. Please tune in to our next segment of our ROMPO podcast, which is going to talk specifically about the ARC Share Approach Model, which is a 5-step framework that you'll be able to use in your practice to really implement these changes.